So everyone, thank you to those of you who have joined us tonight. Tonight, I'm so excited to introduce Dr. Lynch for our session on transgender affirming primary care. Dr. Lynch earned his undergraduate degree from Northwestern in Communication Sciences and Disorders, and his medical degree and master's degree in Medical Humanities, Compassionate Care, and Bioethics at Stony Brook University School of Medicine. He is currently an assistant professor in the Department of OBGYN at the University of Rochester Medical Center, where he serves as the department's education specialist. In addition, Dr. Lynch provides his expertise on issues related to HIV prevention, LGBTQIA+ healthcare, and providing affirming care through the New York State Department of Health's clinical education initiative, as well as through private consultation. Dr. Lynch is also a proud co-editor of the forthcoming book entitled From Margins to Mainstream, A History of Transgender Medicine in the United States. And we will include the link to sign up for the mailing list for further updates, along with tonight's session on the PHR website. And with that, I concede to Dr. Lynch.
Well, thank you very much for that introduction, and thank you for doing all the legwork and bringing me here. It's really nice to, see that there are people who are interested in this. I will not mandate that anyone turn their camera on, but if you are on the fence, it's always helpful to have faces to look at if you're willing, because I'm hoping that this will be more of a conversation than a unidirectional, lecture. I don't know that that's how any of you want to spend your evenings, but it's definitely not how I want to spend mine. So I'm hoping to make this a little bit more engaging. Could people, if you're able to, either with your fingers or in the chat, put like on a scale from 1 to 10, 1 being brand new to this topic area, and 10 being, this is something I'm really focused in, interested in, have a background in, like where would this group kind of fall on a scale from 1 to 10? Okay. All right, thank you. So we're probably hovering, if we average what I just saw, somewhere around 5, 6. So it sounds like you all have some pretty good grounding, and we can maybe move on to some advanced or more advanced topics tonight. So let's just start with getting some of the basics out of the way. So we've all, probably seen this acronym before, but just to make sure we're all familiar with it. Let's see, LGBTQ, let's do 2S, let's do. So of these initials, letters, who can help me just check these off to make sure we've acknowledged what these mean? Pick a letter or couplet and tell me what it means. But I'm all those 9s. Let's go.
I can start us off here. So my understanding is that L is for lesbian, G gay, B bisexual, T transgender, Q queer, 2S two spirit, and NB non-binary.
Perfectly done. So let's get into what the T stands for a little bit more. So T, you said, stands for transgender. What if you broke down this word into 2 words? What do each of these components mean? Anybody? Did anyone here take organic chemistry?
Trans is usually, an organic chemistry opposites. So while cis is on the same side, trans is, kind of on the opposite side.
Exactly. So you got your double bond, and then you've got an atom over here, atom over here. These are across the double bond from one another, and so they're trans, whereas your cis molecules look more like this, right? All right, so what about gender? What is gender?
This is such a hard one because I think gender can be so many things. I think it's often kind of like a social construct is the distinguishing, where sex is a biological construct, gender is a social construct. So how historically, if we're using the paradigm that America has set up of females and males. The social construct about gender is like, oh, females will wear dresses or certain social norms that are associated.
Okay, so norms about what you're supposed to wear. What other things are associated in our culture with gender?
I see gender kind of more as identity.
Say more about that.
I guess it rather than it being prescribed to you, it's something that you can identify for yourself and name for yourself.
Yeah, so it comes from within, like only I know it. It's not something that someone gives me, right? Although the rest of the world is sort of catching up to that idea. In actuality, it is something that we identify for ourselves, right? So what are some other things that our society kind of puts on gender that makes it this social construct, this amalgamation of different things?
It's like certain behaviors, like how someone talks, how someone walks, how someone acts, how someone emotes. Basically, I think almost every facet of life.
I think it's how people look overall. Like someone had said wearing clothes, but I think like certain body physiques or certain facial features or bone structure or certain hair lengths. Guys are supposed to have short hair and girls are supposed to have long hair. Those feel like things that are very much imposed as far as what genders should be doing.
So I wrote down hair lengths. You said something about bone structure. And so we are starting to get over into this other category of sex. So let's just address what that is. What is sex?
Like the term that what I've heard is that it's more of a biologically determined phenomena where you're assigned at birth. Historically has been classified as female or male, but now there's recognition that those categories also don't capture like full sex. So there's kind of an array of sex assigned at birth, such as you wrote, female, male, intersex.
Okay. What else do people mean when they are talking about sex in this concept? Not the verb, but the noun.
Genital, which genitals you have. That's typically how it's assigned is, or classically the way it has been assigned.
Yep, so that's classically one way, whether that's in utero or at birth or afterwards. What's another way that people sometimes diagnose or sex assigned at birth these days?
I wasn't going to say at birth, but I was going to say kind of what we were alluding to, that like social construct is ideas about behavior that perhaps aren't rooted in biology, whereas sex is, from what I understand, a bit more rooted in biology. So facial hair, what we imagine a male would look like facial hair, bone structure, kind of falls more under the sex category.
Okay, and how do you come to have facial hair, or how do your bones come to develop in certain
Like hormones,
structures?
testosterone, estrogen.
Okay. What are other things that people sometimes mean when they say sex?
Chromosomes.
Yep, I was just about to add a genotype, since we just had a genetics exam that came to mind.
Right, and usually they're talking specifically about the X and XY chromosomes, right? All right, there's another piece to the hormones thing, right? So you need hormones. What else do you need in order to end up with that facial hair or with certain body parts getting emphasized or de-emphasized tissue growth?
Receptors?
Yeah. hormones are just the signals. You also need receptors, right? So you've all studied this array of things, the anatomy, which is an end result of hormones being called upon due to chromosomes, and they require you having the certain receptors in the right places that are responsive to the right hormones in order to get certain things developed, right? And so when people talk about sex as though it's this like very fixed and obvious like binary 1, 0, what they're really talking about is a very complex interplay between all of these things. And so even when we're talking about the quote unquote biological construct of sex, it still isn't quite as objective and clear cut as we like to make it out to be. But you're all very correct in noting that if sex is not, fixed and clear cut and firmly in one camp or another, then gender certainly is even further away from that. That we basically made up this concept that everyone whose body parts kind of look a certain way are then going to all share this broad range of characteristics with one another, like what toys they're drawn to, what colors they like, how they should dress, how they should act, right? But we often conflate these two. And so, when you're talking about if you're giving a one-liner and you say, we have a 21-year-old female patient who comes in with, the assumption is if the chief complaint is pain on urination, you're assuming in your head, based on what you know so far, that there's a vagina with a short urethra, that there's been no modification there as well. And so much of what my consulting work is trying to undo this sort of original sin of putting these things paired, and then building an entire medical system upon the notion that there's two ways of being human, male or female, and that everything else is going to line up from sex assigned at birth through how someone identifies, dresses, presents, and engages in healthcare. So a lot of what we need to do when we talk about gender affirming care is try to undo the damage that has been done by making electronic medical records two versions, and you get to pick one and then figure everything else out from there. Does that make sense so far? Okay, so just to complete some language that's important. Someone said cis being the opposite of trans. So that's erasure. So cisgender being the term for people whose sex assigned at birth sort of matches up with how they identify and move through the world in terms of their gender, whereas trans meaning people whose sex assigned at birth doesn't line up super neatly with who they know themselves to be, right? So I am an almost at this point professional trans man. So I was assigned female at birth, clearly identify as a man, and walk through the world largely as a man now without needing to come out often. That being said, there's a time in my life, as there is a time in a lot of people whose sex assigned at birth and gender don't line up neatly, where you're not quite ready to share all that with the world yet. And so this is really important to know as future healthcare providers, that there's a difference between gender identity, which we just spoke about, this sort of internal sense of self, who I know myself to be, and gender expression, right? So someone elucidate the difference for me a little bit.
I think you can think about yourself in one way, but you don't have to necessarily project that in how you look or how you might come across to people, versus gender expression is more of that. Exactly. What are you projecting to the world? What are you kind of maybe exhibiting through a lot of the things we just mentioned: behaviors, dress, clothing, different types of activities, things like that.
Yeah. Exactly. So gender identity, who I know myself to be; gender expression, how I choose to share myself with the world through this lens of gender that we've all decided to co-construct together. And so there's a lot of reasons why your patient might have a gender expression that's not really lining up with who they know themselves to be. And so you might have someone like me who kind of knows that there's something more going on, that they're probably trans and need to look into it, but maybe in clerkship is a little too afraid to show up for work as my authentic self, and so has to show up for work in the most societally appropriate masculine end of what women are allowed to wear to work, right? And so if you just look at that patient walking in, you're seeing one thing and you don't really know what's going on for them under the surface. And so that's why it's really important to ask. Another thing that unfortunately you might, see is someone who identifies as non-binary, which is another term that we had up top, who feels like they need to fit into more of a binary mold when they're engaging in healthcare. So can someone help me understand the difference between someone who's sort of has a binary gender identity and someone whose gender identity is non-binary or beyond the binary? What does this mean?
I think binary is, if we're going back into when you said trans is the opposite, binary is two, right? So two, so either female or male, and then non-binary is a whole array that just doesn't fit into that binary. So you can, identify as neither, you can identify as both. It's just what is not captured in the female or male binary that society has prescribed.
Yeah, exactly. So binary, just like binary code, the idea that we're all just zeros and ones and that's it, versus looking at the world really free from this very limiting structure and viewing gender as something that is much more, kind of free flowing and up to each of us to determine for ourselves. And the more we actually ask questions of people like, how do you identify? What does it feel like to be you? The more we're realizing that humanity is much more falling into this camp than this camp. It's just all that, peer pressure and hundreds of years of repression that ended up with us stuck in this world where there's only two ways to be. But when we talk to our non-binary patients and friends about what it's like to get healthcare, and why I want to bring this up is we can talk about what medications and surgeries we have right now for trans care or gender affirming care. But a lot of them are very much based on the idea that whether you are cis or trans, you're sort of binary, right? You're either a trans guy, a trans woman, or a cis guy or a cis woman. And so when we think about the things we can offer in terms of healthcare, it's helping people achieve one end of the spectrum or the other. And so something that we need to be doing a better job of as we move into the future is recognizing that our goal as physicians is to alleviate stress and increase positive feelings in people's bodies. And that might not for someone be that they are going from one end of a spectrum to the other, but finding the place that they are most at home in their bodies and in society. And so that's just something I wanted to bring up here, because I think it's easy to let ourselves continue within the binary mentality and just, push ourselves beyond all people are cis to all people are one or the other. It's just some people are born in the same place that they end and some people need to cross over. And that's not quite it either. Any questions about what we've talked about so far? Okay, so let's talk now about what it is we can offer in terms of healthcare. So if I draw this menu, this is not a real thing that exists anywhere. It's just a conceptual map for us, okay? I would say that there's like 4 categories of transitional steps that someone might want to take if they come out as a gender identity that's not perfectly in line with their sex assigned at birth, according to what society wants from them, right? There's sort of 4 main categories that you would consider. The first is social transition. The second is legal. The third is medical. And then the fourth is surgical. You don't need to choose something from every category. You don't need to go from left to right or right to left. This is just a conceptual map for us to understand what it is that trans folks or non-binary folks might pursue and where in this healthcare providers actually come into play. So let's start over on the left with social transition. Before, when we were talking about what gender means in our society as a social construct, we talked about your gender being something that the world interprets as predicting certain aspects of who you are, your persona. So we talked about things like clothing, we talked about walking, talking, right? So what kind of things would you do that might fall into social transition, meaning how you engage with the world, that might help you find a place that's a little more close to who you are in terms of those gendered concepts? So what kind of things can we do just by talking to other people or changing our expression to help us live better in line with our true gender identity? What do you think? What falls under the category here of social transition?
To me, first is adopting those behaviors that you want to adopt. So whether that is maybe talking in a certain way, wearing certain items, participating in certain activities, having specific types of relationships, all of feeling free to partake in all of those activities that you wish.
Yeah, that was really good. Let's slow down though a little bit and talk about those in turn. So you actually used a vocal pattern there that I had to unlearn.
Vocal fry?
Upspeak.
Not quite that one. What was that, Alana?
Upspeak. I do.
What does that
upspeak a
mean?
lot. It's so my dad critiques this for me for a lot, because women have a tendency to end a sentence as if they're asking a question. So they will say, instead of saying, oh, this is a talking pattern, they'll say, oh, this is a talking pattern. So it sounds like you're asking a question rather than making a statement. And it is a feature of female patterns of talking.
Yeah, exactly. So I heard that in you, Victoria, is very normal, very common. And
I do it too, Victoria, all the time.
yeah,
Oh, yeah, no, I mean, it's just my voice now. Yeah, very difficult to unlearn, I'd imagine.
it is. Yeah, and it's not a female pattern of talking. It's what you have been socialized to do as someone existing in our society as a girl and then woman, right? That you should be uncertain of yourself, and so you have to end things in questions. Otherwise, I, the dude who's here, might feel like you're challenging my authority, and I might, push back against you. So I had to unlearn that consciously, right? Some people will pursue experts on this. So folks who are speech and language pathologists who kind of specialize or have some extra skills in vocal therapy pertaining to this. So there are, this is jumping ahead a little bit, but like when I started testosterone, that actually changes anatomically the vocal cords. It changes sort of the width of them. And so my voice dropped. The same thing does not happen when someone starts taking estrogen, who went through a puberty that featured testosterone. And so folks who are trans women, trans feminine, who are taking estrogen sometimes need or choose to pursue more vocal therapy to try to increase that pitch and sort of adopt some of those behaviors that we were talking about. So talking vocal patterns, absolutely part of it. And you mentioned like a whole other slew of things. So let's break it down. What else would fall into the social transition category?
A big thing that sticks out to me is activities, which is one thing that I mentioned. So I think about growing up and dance, gymnastics, as opposed to football, soccer can be both, but those types of activities, and then also relationship and romantic activities. So who are you choosing to form romantic relationships with, and who in your community traditionally forms those relationships with individuals?
Yeah, so I mean, activities, I think, feeling free to finally pursue what you're really interested in might be part of social transition. You might argue that some people feel like they need to engage in certain activities so that they can more easily be read the way they want to be read. So, a trans guy who, wants to be perceived as a man walking through the world might feel like, oh, I should join a football league so that people start seeing me that way. But sort of the freedom to just, start doing the things that you really want to do, especially if you held back from them before because they weren't in line with the gender people wanted you to behave as. Let's talk about community a little bit, because I want to make sure we don't accidentally conflate sexual orientation and gender identity, right? So we use the acronym often SOGI, and you'll see this in healthcare. So what does that stand for?
Sexual orientation, gender identity.
Exactly. So often we'll talk about SOGI data. And when we talk about SOGI data, we mean actually asking patients how they identify in terms of sexual orientation and gender identity. On its face, it's very simple. When you start trying to force a big system like an electronic health record to accept those values and do something with them, it becomes really complicated really fast. And I have marathon long meetings trying to haggle over how we ask about pronouns. But basically, we want to understand the difference between sexual orientation and gender identity. So what's the difference between sexual orientation and gender identity?
So I think I just kind of talked us into the exact misstep that a lot of people fall into, but sexual orientation is who you are actually attracted to and who you would like to partake in relationships with, versus gender identity is what kind of identity you personally ascribe to and doesn't have an impact on your sexual orientation.
Yeah. Sexual orientation is sort of outward facing, how I feel towards other people who I'm drawn to sexually, romantically, or both. And gender identity is how I feel internally. It's much more within me, right? Now, when I'm talking to a 101 group and I really want to hammer home that these things are different, I'll sometimes put up a Venn diagram that looks like this. And if you're familiar with Venn diagrams, the overlap is what they have in common. But that's, oversimplifying it to do the 101. I think when you really get into it, how your gender and how you feel in your body, of course, that impacts how you feel about sex and sexual activity, who you want to touch, how you want to be touched, what words you want to use during sex. So obviously, they're not quite, removed from one another. But for the sake of this, I just want to make sure those are different. And then was it Sherry who just put in the chat that romantic and sexual orientation, for some people there's a difference there. For some people they go hand in hand. So your patterns of attraction, broadly speaking, fall into the sort of sexual orientation, romantic orientation, outward facing. What we're talking about here is how I know myself to be internally and how I choose or don't choose to share that with the world. Now, that does involve community, and that's a big part of social transition. So how does community come into play when someone is transitioning?
Having the support, having people who are encouraging, willing to go at your pace, willing to still treat you like a human, versus people who ridicule you or shame you or tell you what you're doing is wrong or flat out stop speaking to you altogether.
Yes. So it runs the gamut, and so if you were talking to a patient and they were thinking about beginning a transition, they're coming out to you and sharing with you that they're anxious about it, or maybe Alana, as the future psychiatrist, you have a patient who is disclosing this among other aspects of their treatment. What do you want to know about your community? I want to know, do they have at least some group of people there that can support them in this? And there's a difference between the biological family and the logical family. So I don't care who you count as your family and if they share genetic material with you, but do you have someone who you can call on who will support you through this? Because transition's hard. It involves a lot of ups and downs, and in some, depending on who you are and where you are, potentially dangerous situations. So as a potential healthcare provider who's supporting a patient through this, you want to have a sense of what does our community look like? And then it involves, as the person going through transition, what parts of my community do I want to be involved in my transition and at what point, right? So you've got this process of coming out. For some people, this is the second or third time they're coming out in their life. And for some people, this is the first time they have to come out. But you don't have to come out to everyone all at once. You can start with friends, Some people are going to feel safe coming out at school. Some people are going to be out in their sort of outside of school life and then have to conform at school or at work with a faith-based community. So there's lots of decisions and constantly negotiating who am I ready to tell and how do I want to show up in certain spaces. So that's part of the social transition menu. Who do I come out to, where, and how? What else falls into social transition?
Some, like, possibly changing your name. Like, it doesn't have to be legal, but.
Yeah. So for some people, not everyone, you pick a name that's more in line with who you are and how you want to be perceived. And often sort of going along with that would be pronouns. You know, what terms do you want people to use when they're not using your name, and they're talking about you in the third person? So for me, I use he, him pronouns. I haven't always historically. And so that was honestly one of the biggest barriers for me when I was finally getting myself to just do it and transition already, was this concept of like, so I'm just gonna like have to call my mom and be like, you now have to use he, him. Like I just like couldn't, it felt very selfish and very self-centered. And it was really hard for me to get over the hurdle of asking people to get used to a new name and new pronouns. And eventually now it's just so second nature, but that was sort of a barrier to me, having to make that announcement and draw attention to it. All right, so those are things in social. Do healthcare providers have to be involved in any of those things? No, not really. I mean, you can choose to engage with a speech and language pathologist if you want, but it's not mandatory. But, you know, things that go in here, we're talking about hair, we're talking about clothing, we're talking about a lot of things. You could, you know, just socially transition and be more in line with who you are and exist in the world in a way that feels more comfortable for you. And this is all you ever choose to pursue in your transition. And that's totally valid. And, you know, if that worked for you, that's great. Some people want to cement it further with going into legal transition as well. So that's where you do have to actually involve bureaucracy to get your legal name changed on passport, driver's license, that sort of thing, change your gender marker. It's becoming easier to do those things because new laws are being passed to make it easier, but you still have to, you know, go through processes. If you get your name changed, you still have to publish it in the paper unless you have, you know, the ability to submit something in writing saying, please don't do that. That could be dangerous. So depending on where you live, those rules might be different. So then that gets us to the med column. So what can we do to help people transition from a medical standpoint?
Hormonal treatments.
Okay, what does that mean?
Top surgery, bottom surgery.
Well, so those would fall into surgical transitions.
Oh, I'm sorry. I completely disregarded that column. I'm sorry.
Okay, let's dwell a little bit more on hormones because it turns out they're kind of tricky. So what do we mean when we talk about hormone therapy for transition?
Estrogen and testosterone classically are ones that I think of, but I'm sure that's a very basic understanding.
I mean, it's a good start. So you got estrogen, and then, you know, plus minus progesterone. I think different people have strong opinions about whether it really helps with breast growth or if it's, you know, posing an unnecessary risk. I know some trans women who really swear by it, that they got no breast growth until they started taking progesterone, and then that really helped. And then if your body is still producing testosterone, and that's not something that you want having an impact on your body, you might want to take something that inhibits testosterone or its more potent friend, dihydrotestosterone. And so we might add something like spironolactone or Spiro, which you all know as being what kind of medication?
Can you repeat that? It kind of got glitchy for a second.
I'm sorry.
I heard progesterone, which you all know, and then it was odd sounding for me.
Yeah, thanks for letting me know. I was talking about spironolactone, which you might take if your body is producing testosterone and DHT and you want to prevent it from having its impact. So what do you all know spironolactone? What kind of medicine is it?
Potassium sparing diuretic.
That's right. So it is used in this case because it blocks androgens. That's also why we use it in PCOS. So if your body is still producing testosterone because you still have testes, you'd want to be on spironolactone. If not, you obviously don't need it. If, on the other hand, you want more of an androgenic effect, so you want a lower voice, you want potentially hair on your face, you want more of a traditionally masculine appearing sort of shape to your body in terms of where body fat goes. If you want sort of the fat pads in your face to drop down a little bit so you're more of a block than you are in a soft oval, then you'd want to take testosterone. There's different strategies that you can employ in terms of prescribing these, what dose you want to start on, how aggressively you dial it up. But in general, there's sort of one golden rule for when you know you've got the dose correct. So like, what is the ideal dose of testosterone or estrogen for hormone replacement therapy for transition?
The dose already in someone's body, I'm guessing.
So like the physiological level? Yeah. So that is a good guess. Some providers like really try to monitor that, but really the golden rule is it's based on what helps the person feel at home in their body. So when you've achieved the sort of like aesthetic and physiological response that you want, it isn't always going to be at the same dose that achieves that for someone else. So, you know, someone could be on a much higher dose of testosterone than someone else and have a very similar sort of physical response to that varied dose. So you obviously want to stay within certain parameters where you're not so supra physiological that it's, you know, potentially posing dangers, but really the goal is to help someone feel better in their body and achieve the kind of aesthetic outcome that they want. And so going back to what we talked about before, that not everyone is binary, you know, I have some friends who are non-binary and they take a little bit of T just to achieve a slightly more androgynous look. But they're not trying like me to, you know, grow facial hair and to have their voice drop all the way down. They just want, you know, to be a little bit androgenized. So like, it depends on the person and what they're trying to achieve. So this group of hormones is what we would prescribe for someone who has already completed puberty. Is there anything we can do for someone who hasn't yet gone through puberty?
Halt puberty.
Yep, so there's something called pubertal blockade. Does anyone know how we do that or how that's done?
GnRH agonist, I think.
Yeah, so you basically confuse the pituitary and shut puberty down for a bit. Really what you're doing is hitting the pause button. You're just biding time. It's not going to magically let them have the other puberty that they're looking for or an augmented puberty. It's just going to sort of stop things for a bit. And what you're allowing for is sort of that social support, making sure that the family and the person, you know, the teen at the middle of it has a good understanding of where they are and who they want to be and what kind of effects that they want their body to go through. Some people who pause puberty decide to, you know, go forward with the puberty that their body was going to go through with no intervention. And some people choose to have a puberty that is more in line with how they feel they are with taking exogenous hormone. So that is something that we can offer. What medical care can we provide to someone who's pre-pubertal?
Can also provide counseling.
You tricked my trick question. So yes, really, when we're talking about someone who's, you know, younger than puberty, we do not engage in medical interventions. And I make a point to say that because newspapers right now would have you believe otherwise. But when you're talking about kids who haven't yet gone through puberty, all of this stuff that we outlined in the social category, I mean, that's mostly what gender means at that age, you know, because their bodies aren't going through those transitions, having those secondary sex characteristics like breast growth or facial hair growth. And so when you've got, you know, a kid who's gender creative and wants to go to kindergarten or third grade, dressing in a way that feels, you know, better for them, that's really what we do. And we just try to create a supportive nest environment, because all of our outcomes data show that if you're just supportive of the kid, they're more likely to have a successful and healthy life than if you try to change who they are, whether or not they end up being trans or they just want to play with gender for a bit when they're young. So we don't give kids hormones or, you know, do drastic things. We really don't do anything until puberty. And even then, we're just kind of hitting the pause button to allow more of the counseling, as Bruce suggested, and time for families and the person themselves to really understand what it is they want to do. Does that make sense? All right, so then what about this final category here, surgical? So what do we mean, Sherry? What do you mean when you say top and bottom surgery?
So my understanding from my experience is that a transgender man may or may not decide to have his breasts removed, and a transgender woman may or may not decide to have implants put in.
Yeah, so the most common gender affirming surgery is so-called top surgery for trans men and androgynous folks who wish to have more of a flat or masculine contour to their chest. But yes, breast augmentation for people who want to have more breast tissue or appear to have more breast tissue. That's what we refer to as top surgery. Top and bottom are really colloquial terms that the trans community came up with. They're really not medical terms, but you know, we use them when talking to patients and talking to one another. So then what is bottom surgery?
Changing the appearance of the genital area to match. So a trans man would theoretically, you know what? I don't know. I'm going to stop talking now, because I know that trans women there's certain surgeries that have been in the works, but for trans men, I actually don't know. So I am going to stop talking.
Yeah, you got pretty close.
Yeah, phalloplasties or vaginoplasties.
Yeah, so when we're talking about external genitalia, and obviously this hooks up to internal wiring as well, you can talk about a phalloplasty, which is the creation of a neophallus. And that involves grafting of skin from another part of the body. So sometimes you'll see forearms, sometimes you'll see anterior lateral thigh. You can also, phalloplasty, not neophallus. That's a mess, but anyway. You can also have metoidioplasty, which does not involve a graft. It takes the clitoral tissue that is enlarged through testosterone therapy and sort of uses that to create a neophallus. The resulting size is substantially less than a full-on phalloplasty, but it's also, you know, sometimes it is what will really help someone feel better in line with their body, and it is less risky given the risks associated with phalloplasty, which obviously involves grafting, much more lengthening of the urethra, which can cause strictures, things like that. And then there's also, as you said, vaginoplasty, which is the creation of a neovagina, often now done in some version of a penile inversion, so taking the tissue that did belong to the penis and inverting it to create a vaginal pouch. Although there have been some that involve intestinal tissue, colonic tissue, and using that as the neovagina. And then when we're talking about bottom surgery, you know, people sometimes count this and sometimes don't, but there's also other surgeries you can have to get rid of the gonads. So you can have an orchiectomy to remove the testes, which will result in a change in the hormone dose you need. And you can also, some trans men and non-binary folks might elect for a hysterectomy with or without bilateral salpingo-oophorectomy. The choice as to whether to remove ovaries or not, it can be personal. There's pros and cons. Can anyone think of a pro to keeping your ovaries?
You could potentially, well, that would be uterus too, but there are transgender men who want to carry their own children.
Yeah, so if you're interested in having biological children someday and you're not ready to do a harvest right now and then have the ovaries removed, if you retain your ovaries, or at least an ovary, you have the potential to do an egg retrieval down the line and then have someone else carry your child. So that's one possible pro. Any others?
I was thinking along the lines of bone health and neurocognitive protection, so you don't precipitate menopause once you stop receiving any type of exogenous estrogen or material that could be aromatized into estrogen.
Yeah, so basically you need some sort of so-called sex hormone. I don't, care so much what it is. We just know that they're important for our bodies to function. Bone health, it impacts so many things, and some of which we don't fully understand, frankly. So if you remove the ovaries, you can remain, stable on exogenous testosterone. But if you ever have a lapse in insurance coverage, a lapse in ability to get the testosterone, for some reason you decide it's not actually something you want to be doing anymore, then you have to find another, exogenous hormone, like go back on estrogen or something to supplement. Whereas if you have your ovaries, you always have a backup, essentially, of sex hormone producing body part. Potential downsides. First, it can be sort of psychologically or in terms of dysphoria, difficult feeling of having ovaries in your body if you feel like they never belonged there in the first place. So, for that, keeping them, there's a downside. And, anytime we retain an organ that could potentially develop cancer down the line, we're holding on to a risk that we could potentially mitigate by having tissue removed. We'd recommend removing the fallopian tubes either way, because those are thought to be at the root of ovarian cancer, at least some of it. So at least that mitigates the risk a little bit. But so those are some considerations. That being said, when we really add up, and there's, I should say, a whole bunch of other surgeries that don't fall neatly into top or bottom. There's facial reconstruction, facial feminization. There's vocal cord surgery that some trans women and trans femme people undergo to try to make their vocal range higher. There's lots of other body modification that someone could choose to undergo. So the concept of the surgery is so far outdated as to not even really mention it, but there's a lot of surgical options. But aside from sort of, the surgical interventions we talked about and hormone prescription, the vast majority of what gender affirming care is treating people with respect and dignity and allowing people to be who they are, even if it makes charting inconvenient. Or our shorthand that we use to one another inconvenient. That's the vast majority of what is really required. You can, be in a setting where you are a hormone prescriber or you're performing some of these surgeries, but even if you're not, you can be a gender affirming care provider now and when you graduate. It's really about seeing people for who they are, using the pronouns that they use, respecting them, reflecting their terms back, and helping them feel better in their bodies. That's really mostly what it is. So that was a long time of you watching me kind of scribble on a screen. Are there any questions or comments that any of you would like to make before we wrap up?
Yeah, I guess kind of one important question that I always think of is ways that you think institutions or physicians can, make people who are non-binary or transgender feel accepted in their practice, whether that be, kind of institutional policies like posting things on flyers or even statements or things that you've seen that would be helpful.
That's a really good question. And it's, what I spend a lot of my time talking about and doing with, in my day jobs and in some consulting sort of stuff that comes along. I think some of it is just like really like basic, just what it requires to be a human out in the world today, and making sure that you're providing accommodating places. So, having gender neutral bathrooms and all gender bathrooms available just everywhere is just going to save people time and angst. Making sure that if you have employees who work in your health center that are trans and non-binary, which I highly recommend, because one of the best ways to make me feel safe is when I walk in and I recognize, that there are people like me that work there. If you've got colleagues, if you've got fellow students, that they can change their email address to match their affirming, name, that their badges can reflect that. So similar for patients, that if you're gonna force them to wear a bracelet that has their name on it, that's the right name. That if you're gonna force, a gender marker on there, that it's the right gender marker, or just get rid of it. So just thinking about, the everyday little things, and making sure that you're lowering and not raising barriers unnecessarily. And then the other entire sort of world that I end up in long conversations about is forms. It really isn't that complicated. I mean, at the end of the day, what you want to do is you want to provide space for a patient who's filling out a form to tell you information that the patient thinks is important so that you can take care of them. And so if you think understanding their gender is helpful for you to take care of them, give them space to tell you what their gender is. Don't force them to check a box like M or F, which is really about something else. And like, I just see this all over the place, because it's just more convenient for computers if you're in one column or another. But, computers are pretty capable of doing advanced things. So we just have to be thoughtful about how we ask those questions. And sometimes more importantly, why? Why are you asking that question? Why there? Why in that way? So I think, mostly it's just putting yourself in someone else's shoes and thinking, how can I just not make this be a barrier for someone who's coming to visit my office? Like, before you try to go overboard in, waving flags and writing these long statements, just make sure that people can be who they are in your clinic, and you're not constantly putting up barriers that'll prevent them from being safe and secure and knowing that they can get good care with you.
Thank you. That was very helpful.
Another question I have that's arising from a project that I'm working on with our asylum clinic at our medical school is we're trying to start this reproductive health counseling seminar series at a local refugee shelter, pretty much speaking to what is medical care in the US, specifically any type of reproductive health care, and how can we, just explain why do we do pap smears? Why do we do mammograms? A lot of things that are foreign to a lot of people who are new to the country. But one thing that I'm finding I'm having trouble with in marketing as a gender diverse, gender neutral type of reproductive health series label is that that's getting lost in translation oftentimes. Even when it's translated, it's seeming like people are confused. They don't really know what it is. I've had some people come and say, oh, I didn't know this is what it would be talking about, different gynecological examination things. I want to know more about that. I thought this was if I wanted to have babies and I don't want any more babies. And I'm like, no, that's not what it is. It's also meant to be inclusive towards all people and anybody who might require other type of reproductive care. So I wonder if you've encountered this or if you have any advice for how to go about this. So far, my solution is separating the program and creating a whole separate transgender, LGBTQI friendly type of programming initiative. But I'd love to hear your thoughts.
I'm not sure that I understand when I just got home. Let me just let my dog out of this room. He's gonna lose it.
Absolutely. Or if anyone else has feedback or recommendations, I'd love to hear.
Yeah, so I think that my question is just what exactly are you trying to cover? Are you talking about reproduction, or are you talking about keeping bodies healthy?
Keeping bodies healthy.
And then, if you have these body parts, this is how we keep you healthy. I like you have to understand the culture of your audience, and if the terms that I'm using as like this very, you know, white hipster guy living in Rochester, New York, like there's a good chance that they're not going to translate necessarily. But yeah, I think I've always had the most success when I just try to really say what it is I'm trying to talk about and then go from there. Because I think we often in medicine end up in these like euphemistic things where like a term has come to mean something, but when you sit down and look at it, it really doesn't mean that. But like we struggle with this too. We just went through this whole thing of we renamed our continuity clinic where our residents see patients and where some of our faculty see patients. It was the women's health practice. And we realized we needed to change it. And then we started having conversations about, well, what do you change it to?
Have you landed on anything?
It's now the gender wellness and OBGYN practice, which is a mouthful. But the idea is, you know, you end up throwing out these things like, oh, reproductive health. And it's like, but we do a lot of stuff for people who aren't here talking about reproduction. So how did we land on that? Or like sexual health? Well, we talk about like, you know, preventive mammograms and things. That's not really, you know, mammograms aren't particularly sexy. So, you know, how can we call it what it is and tell people what it is that what kind of care we offer here? Or if we're saying, you know, this is the kind of thing I recommend, and trying to get away from saying for women of your age, but saying people who have this body part, you know, so that we can make sure we keep it healthy, and just talking about things as directly as we can without packaging them together in these sort of euphemistic terms that I think do get lost in translation, even without language or cultural barriers.
No, thank you for all of that insight. I think it's one challenge is getting everyone to be on board with using, I think, broader terms. And now I'm realizing that there's, you know, other layers to that. So thank you.
Honestly, it's complicated too. I mean, I wrote like a whole essay about this, but I think my mom's an OBGYN. I love working in the OBGYN department. I, you know, worry about my colleagues who identify as women who are in medicine still, you know, getting paid less, still experiencing sexism, you know, all over the place. The fact that OBGYN reimbursement rates are way lower than they should be. So the idea of like removing women, you know, from everything, like that's not the mission I'm on, to, you know, erase, you know, to find one more place where women aren't the default. So it is nuanced and it's complicated, and people have feelings about this, and I want to be open to all those things. So it's trying to make it inclusive without getting so bland or so sort of vague that no one knows exactly who this is for or who is welcome here, you know? So it is complicated.
I think you're right. It is kind of this, how do we make it very clear while also using broad terms? And is that even specifying who we're trying to serve or exactly what we're trying to do, and not being afraid of any backlash or any opposing thought from that?
Yeah, I also think it's interesting how we choose to group things. So like in your seminar, you know, is it possible, see you, Bruce, is it possible that, you know, instead of grouping things according to like sexual health or reproductive health, maybe we're just going to talk about preventive health maintenance. And, you know,
Yeah.
cervical cancer screening might be part of that. But
I think that's
yeah.
actually a really great idea too. It's because we're trying to steer it towards, I think you have a lot of people coming who experience a lot of sexual and gender violence, and that's why they're seeking asylum, or that's part of their trauma. So you want to keep different communities within this larger traumatized community, right? So people feel more comfortable. But so that's why I was trying to focus on maybe having more gender specific or more identity specific groups rather. But thank you. I like the preventative health angle. Any other questions from the group, comments?
Thank you.
Yeah, you're welcome. Thanks for having me.
Very
Good.
much.
Thank you so much, Dr. Lynch. And thank